It's been quite a few months now of this pandemic, and I'll just say sort of like my primary points, and then you can just sign off, after a minute here. I'll just kind of say my points, and then we'll get into it. I'll be reflecting on the FDA's response on COVID-19 from the lens of emergency use authorizations and getting devices out into the market, into the hands of end users. And I think my sort of overall takeaway is that it's curious that the FDA heightened a lot of requirements in our space, specifically of clinical testing, well, specifically human factors, in the middle of a pandemic. And my understanding, and I'm really interested to get the opinions of the experts on the line, but let's talk about it later, sort of, is it justified? And I think many times the FDA says, oh, well, we don't really require these new companies that are inventing COVID-19 test kits or tests or et cetera to have quality systems. And therefore we require more stringent human factors testing specifically, as well as other things. And I just think that's kind of an interesting perspective to heighten regulatory requirements that have been sort of constant for a decade in the middle of a pandemic. So I'll talk through what have they been asking for and what was the evolution of what they were asking for, and also comparing what their expectations were in 2020 to my practice of human factors over the past 10 years. And then kind of questions as to what does this mean for the future once this pandemic ends? So, here's some information about me. I am a professional industrial engineer with a background in mechanical engineering. I founded UserWise 7 years ago in an effort to help companies navigate the new human factors requirements, both from the FDA and worldwide. And I sit on the International Standards Committee for 62366. And UserWise does consult to the FDA on human factors enforcement. Specifically, we're working on a project to investigate the effects of training decay on human factors validation outcomes. So the idea that you might train someone in the field to use a medical device and then they might not use it for quite a while. Think about an AED or even something that might even be used a day later. How much are they going to forget, and how does that weigh into the way that you should test the device during development? So our goal at UserWise is to co-create safe and usable medical products. Here's a couple of products that we've worked on, like the Shockwave lithotripsy catheter and the Prescient surgical clean incision wound healing device. These happen to be surgical devices. We work on a wide variety of devices. Our team at UserWise, we're all human factors engineers, all doing the same thing with some capabilities in UX, UI, design. We will design instructions for use. We will conduct usability testing. And that's mostly our area of specialty. Though we did take a really deep dive into emergency use authorization compliance starting in March. So we're located in San Jose, California. And as I noted, our core competencies are user research, usability risk analysis, and risk management in general, usability testing, and compliance. So what did UserWise do? And I guess before I move on, I just want a little tangent. I need some I need some more confidence from everyone on the line, because I was working on an instructions for use yesterday, and on a whim, I decided to hire someone for $10 in the Philippines to design, illustrate a picture for the instructions for use. And I asked them to omit the photo of my face from their diagram, but they didn't. So I woke up to this picture of myself, and my husband commented that I look like an Oompa Loompa. So maybe, I don't know if we could take a poll, like, is this what I look like or not? So maybe Joe could maybe administer a poll and we could kind of discuss and debate.
I could do that, or I could categorically say that you need a better artist. I know a little bit about this area, and I'm going to go with that as my professional advice.
Wow, that is quite the double chin. And anyways, so moving on. So here are some of the products that we worked on over the course of the year. We assisted with regulatory compliance and submissions for about 15 medical products, including surgical and N95 masks, as well as novel masks, COVID-19 test kits, antigen test kits, molecular antibody, mostly focusing around home use, home collection, and point of care. I would not recommend, working with UserWise if you're only going for CLIA labs, because our specialty is home use and point of care. So a lot of sample collection and also point of use diagnostics. Also ventilators, we worked on 2 different ventilators, one of which got an emergency use authorization. It was the second one to be authorized, and then the other one still in process. So that's sort of what we worked on, bringing that to life over the past year. And then now I'd like to just give some high-level background to kind of understand what are these products I'm talking about. I know.
Question.
Question?
The EUA approved ventilator, is it in production?
So unfortunately, the Collabs Ventor never got into production. It was the second one to get an emergency use authorization, and that authorization happened in, I think, April. It was kind of like an insanely quick authorization that we facilitated, but then they couldn't get the funding and they didn't end up pursuing it.
Not shocked. I never hear about insufficient ventilators anymore. Now I know I'm thinking from a US perspective, and third world I'm sure could use some, but are you aware of anyone making ventilators who wasn't making ventilators before, and or if GM or Ford are still in the ventilator assisting business?
I don't know about the commercial context of ventilators, but I do know with the clinical needs, it's far reduced. When this pandemic hit, everyone was running to ventilators. They wanted to use ventilators, invasive ventilators, that is, with the endotracheal tube. And those have gone out of style. They found that it's much better to just use a BiPAP or less invasive solutions for these COVID cases. And only when it progresses past a certain point, should they use a ventilator. So the clinical guidance changed pretty early on in this pandemic, which gave rise or negated the need for so many ventilators. I also think there's a lot of excitement around ventilators with NASA working on ventilators. Tesla even said they're going to make a ventilator. And I think they kind of didn't know what they were doing, to be honest. All these players came into the field and started making ventilators, but they honestly had no business making ventilators. And in the same way, we had a lot of suppliers of medical products put their hat in the ring, get government contracts. We saw what happened with California, where there was a vendor who had promised millions of N95s to the California government, and then they dropped the ball. I think it was counterfeit product or something. Does anyone know further information about that? I don't remember the details, but.
Not about the N95s, but as someone who tried to help get supplies from and to, it was an unmitigated, well, you get the idea. There was so much fraud that nobody trusted anybody. And it was, where's your proof of funds? Where's your proof of product? Is it on the ground? No, but I need to see it. It just never went anywhere. It was misery. Daniel Shepard favored us with a link that GM and Ford have, in fact, wrapped up their ventilator production and they are making cars again.
Oh, wow. That's sort of what my business did too. I mean, when this pandemic hit, all of our studies were moved, and 40% of our work is related to studies, and most of the other work is related to preparing for, reporting on, and submitting studies to the FDA. So it was a pretty scary time in March and April to have really nothing going on and 14 employees on payroll. So at that time, we pivoted into helping companies to pursue submission of emergency use authorizations. And that was a really great opportunity for us to keep moving forward. But then sure enough, there was this backlash of all this positive backlash of a lot of usability testing. And we've been quite busy since then. So we're able to really focus again on usability testing. And I think that that's what a lot of different industries saw. Though I do think the car industry will be in trouble. And I believe that in my commute to work on 101. I mean, what a delight these days. I don't know if anyone else is in the Bay Area, but there is no traffic. And
I can tell you that oversharing here, and we're way off topic, but for those who followed my travails at all, some years ago, I invested in a privately held medical device company and we lost a lot of money. And my wife then forbade me to ever invest again in my life. We just sold our house. And we decided that we were going to split the proceeds in accounts that we could manage as we saw fit. In other words, I'm allowed to trade again. And so I'm looking at stocks again, which was a great hobby of mine years and years and years ago. GM is hitting new highs. I mean, I don't know historically, but the car companies are, you know, Wall Street looks many years ahead and quarters ahead. And they see exciting developments with electric and the like. I don't know that the auto industry is in disarray, especially given how People are more skittish about flying and other means of public transportation. So at least, our pod can be in our car. Who can
And
say?
the RV business, I'm sure that's thriving.
It's like a Freakonomics thing where you wouldn't think. Anyhow,
But
sorry.
anyone else on the line sort of have any comments around ventilators and maybe the lack of demand that has emerged? Or, I mean, long story short, there were just tons of excitement around it. Hundreds of companies that threw their hat in the ring, and a lot of them kind of fizzled out. So I'm not too sure what the future is for ventilators in this pandemic. The comments are welcome if anyone has any more perspective. So in the meantime, I'm just going to quickly go over what are the types of COVID-19 tests, just a little bit of background info to kind of really get into these topics a little more deeply. And I know most of you already know this, but there's 3 types of COVID-19 diagnostic or screening tests. There's the molecular tests. They detect the virus's genetic material. Antigen tests. They detect specific proteins on the surface of the virus. Both of these types of tests can diagnose an active infection. If you go into a clinic, most likely, hopefully you're going to get a molecular test because that's the gold standard, though it does take a while, but it can be 99% accurate. While antigen tests actually are permitted to have rates of accuracy as low as 85%. And again, you're welcome to correct me on that. It was 85% a couple weeks or months ago, might have elevated. That's pretty low, 85%. But what's great about antigen tests is that you can do it at the home and it will tell you if you have an active infection. So my favorite test and my most controversial test is the antibody test. It detects antibodies that are made by the immune system in response to the threat. So it does take some days for these antibodies to emerge in your blood. And the FDA is very clear that you cannot use a test panel for antibody tests to diagnose an active infection. It's just for screening. And also, the FDA is very clear that the presence of these antibodies does not mean that you're immune. And based on these 2 concerns, I believe that the FDA has been actively obstructing access in the marketplace to antibody tests because they're worried that people are going to be over-reliant and misinterpret these tests to mean that you have an active infection or misinterpret them otherwise. And they're also worried that people are going to think that they're immune, stop wearing masks, and change their behavior. But I disagree. I think more data is helpful. And this belief of mine that antibody tests are extremely useful for better understanding what's going on is backed up by China's recent decision to require both PCR tests or molecular tests and also antibody tests to screen people coming into the country of China. Because it really is true that if you have an IgM antibody, which is the early appearing antibody, you very likely might have an active infection. If you have the late appearing antibody, IgG, it's more indicative that you already had the virus previously and you might be over it. Any questions about that? But that's my big concern with FDA enforcement. I think that all of their decisions over the past year have really made it difficult for antibody tests to both access point of care settings as well as home settings. And to date, we still don't have access to these antibody tests in the home, which I think is a huge loss for the US public because they're really easy to use, in my opinion. So there's 3 different samples, well, there's many different samples that could be collected at a high level. There's the swab, sort of nasal and throat swab, used for molecular and antigen tests, saliva, and also blood. So just to be aware of the samples. And then there's at a high level, kind of 3 different areas of or levels of enforcement by the FDA. So the FDA could approve a diagnostic test to only be used in a CLIA lab. So that lab has oversight by other government agencies. So the FDA is less worried about people committing use errors and making mistakes that would compromise the outcome of the diagnosis. So here in CLIA labs, there's a lot less government oversight, less testing required. To access a point of care, oh, is there a question? Okay, just let me know. And then if you want to pursue a point of care setting, so that's
Sorry, I was on mute. Jonathan, did you want to share what you wrote me?
Well, I was just going to lean on what Shannon said about the antibody tests, that we have a lot of discussions around that category, and we think that there's going to be a lot more engagement in antibodies once the vaccines are much more prevalent in the market, because there's going to be a lot more interest in the antibody factors once people start to take those vaccines.
Well, that's great news for antibody test kit developers. So here's a topic I haven't had a moment to research, but do we know for sure that the Moderna vaccine, the Pfizer vaccine, that they in fact will produce an antibody response? Or I also heard that it's possible that vaccines can induce only responses in T cells, B cells, and other indicators apart from antibodies.
A lot of the antibody tests that are out in the market today are screening, for certain factors that are related to the protein, the nucleocapsid protein, and so obviously there's lots of discussion. Antigen, and so there's a lot of discussion in the antigen screening market about spike protein, the actual capsid. But when it comes to the antibodies, I think, people are starting to learn about these things. I think the antigen was much more simple for everyone to understand.
Mm-hmm.
And now with like you mentioned, IgM, IgG, and some of the other interrelated immunocharacteristics of the body will start to become more, communicated and publicized and make its way into the broader consumer market. The thing I think that is the biggest barrier is, of course, blood. The fact that blood is being seen, that there's piercing of the skin and things like that is probably the bigger factor. Slowing some of that down. But I think over time, we're going to see a lot more post-vaccine engagement around antibody.
So slowing that down with respect to FDA enforcement, that is, the FDA is concerned that you're going to have all these needles and blood strewn about our U.S. public, and that's why they're slowing down?
I'm always looking at it from a consumer perspective.
Oh, okay.
So when we interview people, there is obviously there's that first barrier. If you have somebody who's familiar with diabetes or something like that, we don't have those problems. But if you have a pretty much a layman engaged with antibody test, there is a concern for blood, for splatter, for what other things can be a factor. Could I get another infection, hepatitis? There's a worry. But I think that, that's why saliva, nose swab, nasal swabbing, and things like that.
I'm just looking at the time, and having known Shannon and Jonathan for a while now, I know that we could easily careen off into, another discussion. And because I know how many slides she did prepare, I want to ask the group if there's anything in particular you want to make sure we hit in this call. Write me a note so that we can address it. Because as you know, these Friday calls are a bit more free flowing, and we take it where, the audience wants to take it. So if you have something in particular about human factors or COVID testing, et cetera, please specifically write a note. I'd like to just offer that while I'm arguably more informed about this area of COVID and testing and vaccines than the average American, as someone who got a vaccine yesterday, and most of the science is still over my head despite the facilitating role I play here, I'm thinking, ooh, I got a vaccine. I don't have to worry about all those tests now and everything. Now, I know that's short-sighted and ignorant, but if I'm thinking that with the degree of information that I have and the friends that I keep, just imagine what the average person is thinking. I don't necessarily see the corollary, Jonathan, that you're saying that with vaccine comes more interest in tests. I'm less interested in being tested. I'm immune now, right? I know I'm not, but
it's only 5% effective. So wouldn't you be curious to know that you generated antibodies if in fact the vaccine induces antibodies?
Okay, again, I have no problem exposing my deep ignorance here. Antibodies, what are you talking about? All I know is that I got a shot and they said I'm supposed to be better. Now, that's a degree dumber than I am, but not by a lot, not by a lot. Jonathan, now I know too, because we've had private conversations, you're in the testing business. What specifically are you guys working on, have produced? Are you in production? Or have you commercialized? What's the state of, tell us what you worked on.
So in a nutshell, we produce upwards of 500,000 rapid antigen tests per day that are being distributed from New Jersey. So domestically, it's 100% American production, and it's being distributed through McKesson, Cardinal, and DC to pharmacies, to practitioners, clinics. Shannon has been very helpful in helping us get through and get EUA authorizations. We are very aggressive in trying to get the market out there because we want to democratize testing and screening. That's very much our goal. And then building technology platforms that help people understand all this. Like you were mentioning, well, I got my vaccine, who cares? Well, there's a lot of people who care, especially your healthcare providers and things like that. So providing the right technologies to help them engage with you, that's part of Intrivo, the company Intrivo's goals.
Quickly, so everything you make, you're selling and profits are rolling in?
Yes, we're selling a lot every single day. We cannot keep up with the demand, and it's quite extraordinary. I mean, I thought that we would need to go out internationally. We can hardly keep up with the American need for these tests. And just the nice thing is that they're being used. People are being trained. They're being educated about the test, and that in itself is a really positive step in terms of use factors. Because I think as people start to see these things and it becomes more common, we're creating a shift from diagnostics in the lab to screening as a daily or a weekly or an engagement with consumers and part of the health system and the wellness system.
Before I throw you back into the attendee gallery, just for my satisfaction, did you guys meet through Premium?
Did I?
You?
Oh, absolutely. Yes.
Yes.
Network what you created, the lights.
Yeah.
Yeah. Okay, Shannon, I think
thank you.
250 slides left.
Thank you, Jonathan. And thank you, Joe. I mean, this group has just been a tremendous opportunity for me in meeting so many prospective clients. So just a moment, hats off to Joe for having this group. Thank you so much. Especially during the pandemic when he can't go to any conferences, very challenging. But yeah, just to kind of circle back on consumers don't like blood, they don't like pricking themselves. Yes, it's really scary to prick yourself for the first time, but it's just so convenient to have a test in your home and not have to drive somewhere or wait in line, etc. And I am frustrated that it's like, even if we can't even get to the point of seeing whether consumers are afraid of blood, therefore they won't buy lateral flow kits, because FDA won't allow it. The FDA will not allow home use of these blood serology antibody kits, and that frustrates me. And it also might be a consideration that the developers don't want to invest in the testing that the FDA is requiring, and that's a whole other conversation as well. So any other comments?
No.
So this is a timeline. I don't need to go through the whole timeline, but it basically reviews what happened over the course of 2020. These slides will be available. So I'll just kind of breeze through the overall timeline. We had the first US coronavirus case, January 21st. US declared a public health emergency, February 3rd. They declared it a pandemic shortly thereafter. And then the FDA did come out with a policy pretty quickly about diagnostic tests at a high level. They authorized the first PCR or molecular diagnostic panel in March 15th. So starting in March 15th, we were able in the United States to run samples and find out whether someone was positive or negative for COVID-19. And then from there, hundreds of developers continued working on developing different options, again, molecular antigen and antibody tests to characterize whether someone had COVID-19. The FDA also issued a blanket emergency use authorization for the molecular diagnostic tests developed by CLIA laboratories. Again, CLIA is sort of another government oversight process by which the FDA is a little more confident that whatever they're making is going to be safe. And I've heard a lot of grief from regulatory consultants saying that this decision was actually not a good decision and they should submit their tests to the FDA because what they're doing is kind of crazy. So just it's an example of far reduced barriers and reduced FDA enforcement. And I'm interested to see in the future, do they continue having this reduced level of enforcement because in the end they find that CLIA laboratories were fully equipped and fully capable of producing accurate diagnostic results? If so, maybe we have a regulation in place during normal times that doesn't make sense and is too burdensome. April 21st was a big day because they authorized the first home collection test kit by LabCorp. And so that's the idea that you could collect a sample in the comfort of your own home without having to go out into public and expose yourself to the pandemic. You could collect that sample at home and then mail it in. So that was very exciting and did require human factors testing where we bring in at least, in this case, 30 lay users and demonstrate that they're capable of collecting a sample and packaging it up for shipment without presenting undue hazards to the mailman or themselves or getting an erroneous result. This is the most spicy part of 2020, I think, where they allowed a notification pathway for antibody test kits. Again, my favorite test, antibody tests, where you use blood. So basically, the manufacturers could just email the FDA and say, I have this test. I'm just letting you know that I'm going to sell it. But the catch was that you could only sell it to CLIA labs, which is actually a customer that doesn't want this product because they have high throughput analyzers that can more efficiently and more cheaply give a result as to whether you have antibodies or not. So actually test kits, these antibody test kits are made kind of for a point of use at-home setting where you don't need all this fancy equipment. And the FDA basically said you can only sell them to customers that don't want them, which really frustrated me. And then they still have not issued any guidance, any formal final guidance about how to access home use. Though we have all the information at UserWise, I have talked and met with the FDA multiple times and we know what the steps are, but they're keeping it a secret from everyone else. And I know I'm being dramatic, but this is something that I care about. And if anyone else wants to join me in trying to change the world here, please send me an email. But anyhow, they opened up this notification pathway and all of these test kits flooded the market, maybe 80 of them. And a lot of them actually were giving erroneous results. So there was either a member of the House of Representatives or a Congress person, I don't remember, but they wrote some upset letters to the FDA. I believe it was the commissioner. And basically, ultimately, this notification pathway got shut down. The idea that you could just let the FDA know that you were selling it and then go ahead and sell it. Well, it wasn't shut down per se. They just tightened the requirements requiring that these manufacturers send data to the FDA and also submit an emergency use authorization within a certain time frame after that notification. I know that was a lot of content that I just jumped into, but I thought that's probably the most important thing I wanted to say on this call.
Thank you.
Any questions so far?
I'll let you know.
Okay. So then they issued all these templates. You'll see all these images of Word documents where it's providing very clear instructions on what testing and what steps do you need to take for your COVID-19 diagnostic or screening solution. They issued one for blood tests to be sold in CLIA laboratories. They issued one for hospital settings for antibody tests or for serology tests in general. One for CLIA laboratories for molecular tests, and so on. And what's great about these templates, I thought it was really efficient, and I actually don't have enough experience with like templates and guidances to know whether they've ever done this before, but I love that they provided Word documents where you just edit the document and fill in the blanks rather than interpreting a guidance and then making a new document. So maybe someone on the line, I know we have some FDA experts on the line who could kind of say whether they've ever done that before, but maybe that's a change that was made in 2020 that maybe could stick, I don't know. So instead of having a guidance, they had a template that was really easy to use. Though obviously they, as a government agency, they didn't include all the information we needed, which continues to propel the need for consultants, which is unfortunate. Because if the FDA could just make everything crystal clear, maybe entities wouldn't have to hire consultants like myself or other regulatory consultants. And then finally, just fast forwarding to December 15th, the FDA authorized the first over-the-counter rapid antigen tests. That was a huge deal because now we can get these antigen tests. You saw a picture of this COVID-19 AG card here in the middle here. So you just order this or pick it up from CVS or wherever you want to get it, or call Jonathan to get his antigen test, and then use it in your house. And then you don't have to go anywhere, and that's very exciting. So yeah. And then this is actually the FDA's perception of their accomplishments in 2020, and I think it really is impressive what the FDA got done in 2020. They issued 11 of those templates that we just saw, 26 guidance documents. There's also other guidance documents, for example, a blanket emergency use authorization for UV light disinfection. They basically created a permissive context by which you could develop a product like that specifically for COVID-19. They had 608 authorizations. They worked with shortage mitigation activities. For example, if there weren't the right samples or materials in order to develop and test all of these tests, they were proactive in assisting with accessing these things. I remember back in March and April, the ventilator developers that we were working with, they were really worried about being able to access all the parts that they needed in order to create a ventilator. And there's some pretty severe shortages back then. I'm not sure what it looks like now. And if anyone knows, do chime in. And I call into these town halls every Wednesday. The FDA hosts a town hall about diagnostics. And this week they noted that they receive 40 emergency use authorization submissions every week, which is a very, very high number. 40, it says like 120 per month. In fact, at this point, they have paused review of all other PDUFA submissions. And I think that that's really interesting. They'll allow IDE submissions. They'll allow pre-submissions, to my knowledge, but they will not allow you to submit, from my understanding, a 510K or de novo application, et cetera. So basically the FDA has halted authorization and approval and clearance of all other medical devices that don't have anything to do with COVID-19 in the interest of pursuing these emergency use authorizations. And the director, Dr. Timothy Stenzel, noted that what the FDA had been hoping for is that the excitement around diagnostics and ventilators would kind of die down, and they would just get sort of this trickle of authorizations and everything would be cool by now. But that's not how business works. When there's a pandemic, everyone's, again, going to throw their hat in the ring and try to make something of themselves and create a new product. So it's only ramped up, all of these new authorizations. So I think what we will see in 2021 is a lot more competition and kind of the commodification of test kits potentially due to this steady stream of authorizations, new companies coming into the mix and competing.
Rob and Larry, can you confirm that none of the projects you're working on that are not COVID related are proceeding through FDA at this time? Shannon, please continue. I'll let you know what they say.
Yeah, and you can submit pre-submissions and IDs, but oh, and they are kind of wishy-washy about it, where they will accept some things, and obviously anything breakthrough designation, they're definitely reviewing that. But otherwise, they're generally putting everything on hold, and it sounds like they might accept things here and there, but not really. But yes, please let me know what you think. So these slides are about how you conduct a study. So there's two types of studies to try to get access to markets other than CLIA. So again, CLIA, that's a lab setting where you have trained laboratorians working with these analyzers. If you want to sell your product to a hospital or a restaurant or someone's home or just anywhere that's a CLIA waived or well, specifically in this case, a CLIA waived setting, so a hospital, not a restaurant, not a person's home, maybe a nursing home. If you want to sell to those entities, then you need to prove that an untrained nurse can perform your test accurately. And the FDA has reduced their burden of proof in this for this particular study, requiring 4 to 6 healthcare providers. During normal times, we see a minimum sample size of 15, so that's helpful. But what's interesting is that the FDA is forcing us to combine clinical and human factors endpoints, which you'll see a lot of blog posts and talks from UserWise talking about why that's a terrible idea to combine clinical and usability endpoints. But the FDA is requiring this for point of care, where you need to test with 30 positive and 30 negative patients and 75 negative patients if you're combining this with your clinical agreement study. So the implication there is that you both have to run a clinical agreement study and then also this point of care study if you want to sell your product to a hospital. So in some ways, this configuration is a lot more burdensome than the normal state of affairs, in my opinion, but also in some ways permissive due to the low number of operators. So what if I want to sell my COVID-19 test to someone's home or to a business that doesn't have a CLIA waiver? Well, I need to prove that untrained lay people can perform the test accurately. So this is a picture of the UserWise Usability Study Lab where we have a layperson swabbing their nose, sitting in a living room environment. And if you want to pursue a prescription-only pathway, you can test 15 individuals self-testing and 15 legal guardians testing their child. And then if you want to pursue over-the-counter where your product is sitting on the shelves of CVS, then you'll need to ramp up that sample size astronomically to 100, where you not only have 100 sessions, but also 150 participants. That is 50 individuals doing self-testing and 50 individuals testing another person with a requirement for at least 25 children. So this is sort of an insane level of sample size, because again, traditionally we would be required to have 15 individuals only, maybe 7 with a pair and 8 with individuals, or maybe 15 and 15, but never beyond 30 during normal times. And you can imagine that this astronomically increases the cost of this testing. As they do with normal times, they require varying educational backgrounds, and they also included in their template that they suggest including Spanish speakers, which is quite a hot button issue with me as well, as the FDA has never previously required Spanish speakers for this type of testing. And this also makes your testing far more complicated and extends your development timelines. So I'm a little bit confused about why the FDA is racing to try to bring these products to market, and they brag about like, oh, we approved all these authorizations, but they're also doing things that explicitly slow down the whole development process. In order to pursue inclusion of Spanish speakers, you need to author instructions in Spanish, and you need to certify that translation. You need to recruit Spanish speakers for your study, and only about 1% of the US population speaks Spanish only. So it actually is very, very difficult to find Spanish speakers who are going to come into your study and actually use or need your instructions for use in Spanish.
Quick plug for Peter Argondizzo. He's one of our premium members, and he's my go-to for all matters translation for medical. So if you need, I'll make that introduction.
May need. And what's the name again?
Peter Argondizzo. I'll take care of it. I'll send you both a message.
Good for me to know too.
Before I have Rob contribute from what we were talking about before, in the heat of a pandemic and the panic, and everyone's talking about COVID every day, and rightly so, it's not as though human factors for other medical devices are any less critical to be, effective for people to be able to use and administer. So, I mean, on one hand, it's like, it seems logical that, we're talking about COVID here. We really better make sure that people know what they're doing, because false positives would be terrible. And yet, isn't that kind of true with other medical devices too? And therefore, is this like an unfair standard? I don't know. I think that this is really an opinion question more than anything.
This is based on pure opinion, yes. And I just feel it's bizarre that they're slowing down development of emergency devices that are badly needed by heightening requirements, such as requiring Spanish speakers in a study. It boggles their mind.
Rob?
I really don't think that the FDA is actively trying to slow anything down.
Well, yeah, of course their intent is not to slow things down.
I don't even think it's passive aggressive approach. I think this is really just a function of resources versus workload. they're staffed in the IVD group, or they're understaffed in the IVD group for normal volume. They historically, and even in recent years, like 2020, have the worst performance rating for 510K clearance of any division in the entire FDA.
Wow.
And most of them, the accent's extremely thick. They're chemists that maybe weren't born in this country. And they do not seem to be on the same page as the rest of the divisions of the FDA when it comes to trying to help industry use the least burdensome approach. They seem to be made, on their own agenda of tightening things up. In fact, I've even had third-party reviewers say they refuse to work with them anymore.
Oh my goodness.
Okay, so that's how bad that group is. And then you take that group and say, oh, here's 2,000 EUAs, please process them, but don't slow down your normal workload. And your funding will be based on your normal workload performance, because there's no funding based on the EUA performance. So even though they've gotten a lot more staffing and they've gotten maybe some more funds, they don't have anywhere near the number of resources they need to process what they've got going through their system. And only recently, 6 months later or more, the FDA is now saying, okay, we'll move people from one division of the FDA where we have less volume and triage and move them over to these other divisions like IVDs to make additional resources available. But that's sort of like taking somebody that, it's like asking Joe, hey, Joe, would you come over and help me with my regulatory filings this week?
Do I have to be the example here of incompetence?
Well, it's not that you're not competent, just what I do is not your competence. You have your regular job. You're not, your regular job doesn't need to be done. And just saying, please come work for me full time and without any training. It's
the next time somebody calls me incompetent, I will correct them and say, no, I'm merely not competent in the thing you wish I were competent in.
Exactly. All of us have things that we're good at and some things that we're not so good at. And asking somebody in orthopedics to review an IVD test is just pointless.
You wrote me something.
A chemical engineering or chemistry degree, don't bother.
You wrote me something.
Yeah.
And that was what?
So we have had some success with EUAs recently, getting active dialogue with the FDA, responses, questions, them reviewing, giving feedback that seems to be productive, but only in 2 tests that were novel. They weren't serological tests. They weren't tests for genetics. They were completely different types of tests using technology that nobody else has ever used to detect COVID. And we specifically and strategically targeted children to be the testees. So they're designed for school kids. When you get on the bus, you do this test. And you pass the test, you get on the bus, you fail the test, you stay home. And we actually did the human factors testing with 5-year-olds. So if your 5-year-old can do it and do it well, without any questions, it's probably a pretty well-designed test. And both of these fit really well in that paradigm. They were both less expensive, one of them is actually free. The other one is pennies. I mean, we're talking less than 25 cents per test. Both of them allow tracking real time with software, and it can be even made publicly available, and that's the intent, is to give it as a resource to the CDC for tracking as well. So by strategically picking user groups they're going to help show this can be used by children, and both of these tests have been shown in clinical data to be effective on populations that are asymptomatic. So they test positive serologically, they test positive on the genetics, but they have no symptoms. But these 2 tests also work on them. And so it's that's a pretty high bar, but that's what the FDA is looking for. They don't need another serological test. They have hundreds of serological tests that work, that they've given authorization to. They don't want any more. They can't refuse your submission, but they can basically not work on it and not give any resources to it, so it doesn't go anywhere. But
But isn't it curious that they still haven't authorized a single serological test for home use?
they haven't authorized the test for home use. They've authorized the sample collection,
Sample collection.
and they've authorized point of care, but in very limited cases. And their concern is that people won't use the test correctly or won't interpret the test correctly. And I don't disagree with them, because I've worked on all kinds of serological tests, including pregnancy tests, and people still don't know the difference between 2 lines and 1 line and a plus and a minus. So,
but the pregnancy test is legal for sale to consumers, and consumers have access to it. So I guess I just disagree. I guess this is just an opinion thing. You know, I think we have the right as citizens of the United States to have access to this product, and the FDA has made the decision that we cannot.
They've made the decision that they want companies to provide additional testing above and beyond the norm for this to be a home use test.
Mm-hmm.
The reason is they're convinced that people will not interpret the test result correctly, or like you had said, won't won't continue to isolate themselves. Or, but
that makes a lot of sense to me. I mean,
I'm not saying that people shouldn't have access to the test, but that's the FDA's rationale behind why, we already have many of these tests approved, so you can go to your urgent care clinic and you can get the test there, but we're not making it available for home use as an over-the-counter test.
with the exception of some pregnancies, a false positive will not have population health issues.
That's correct.
But
Yeah, but there are all kinds of other tests out there that are other types of communicated diseases, and they don't allow it for those either. That you can't point to a test where it's going to infect the entire population if you have it, where they've allowed it to be OTC.
yeah, no, I don't see
It's
it.
just a policy the FDA has across the board. Whereas if you want to test certain blood chemistry things, they will allow if it has a very low risk and it's a moderate, it's not even moderate, but low difficulty of completing the test. But they're really tough and unreasonable and very different from any other country in the world in terms of OTC tests. They're being very difficult to allow anybody to use these tests OTC, whereas the rest of the world's allowing it. And I think
That's curious to me.
I think it's going to have to change. I think paradigm will have to change, but I don't know if it's going to happen during this COVID pandemic. I think it'll be the next pandemic it happens to.
I just put Shannon's
Different policy leaders.
I just put Shannon's PDF in premium for anyone to download if they like, because as expected, as fluid and delightful as she is, we hardly made a dent in.
Well, the good news is I was able to say all the points that I wanted to say. I just
That
kind
is
of
the-
pressed them into the slides I had.
And I see you've stopped sharing your screen, which is fine. I think, and deliberate. Yes?
Yes,
Okay.
I've said my piece.
What if I were to make a clip of today's talk and it were just the next 3 to 5 minutes of you expounding on the topic for today, because we did take it in a couple of different places, what would you have be the nugget of the essence of today's talk?
Sure. 2020 has been an adventure for UserWise. We started out with authorizations of ventilators, masks, and IVDs for COVID-19. And we saw the evolution and different policies come out of the FDA and track those very closely. It was pretty interesting to see the lack of discussion between the IVD group at the FDA and the human factors group, which is the group that I deal with day in and day out. There was no communication. I repeatedly tried to connect them over email, but it led to heightened human factors requirements that were not the least burdensome approach for manufacturers and developers, thus delaying access to these test kits that I think we really need, both molecular, antigen, and antibody test kits in point of care contexts and also home use contexts. So in conclusion, do reach out to me if you need any help with specifically human factors and usability testing in any medical product, and we're happy to assist.
Would it be fair to summarize what you just said as it relates to human factors needs for COVID? It's hard, it's cumbersome, it's going to take a while. You need someone in your corner. I know a gal, call Shannon.
Thank Thank you. Yes.
Okay. I think that's as neat a button as we could put on today's call. So why don't we leave it there? And I know how scarce your time is. I know April 14th is just 90 days away or so. So I'm sure I speak for everyone on the call and anyone who might watch this later. A big MDG Premium hug insofar as it's virtual to you, that you have a safe and easy delivery.
Thank you.
Okay. Everybody, next week we are going to be, let me tell you, talking with Jeff Sauter is going to be talking about trends in terminal sterilization and the emergence of E-beam and X-ray. Way over my head, but it sounds impressive. Thank you, Shannon. Thanks everyone for joining us today, and we'll see you next week.
Thanks, Joe.